say a few words about our motivation for bringing this panel together. 3IE's evidence program on innovations in immunization began in 2015 with generous support from the Bill and Melinda Gates Foundation. The program has supported 7 impact evaluations and 6 formative evaluations. As part of the program, we built an evidence gap map looking at the state of current evidence on the types of policies and programs evaluated and the outcome measures in the immunization sector. As we officially launch this EGM today, we hope the discussion will help unpack the lessons from the existing evidence on immunization and how it adds value in the present context of COVID-19 with a global push for increasing COVID vaccination coverage. To discuss all of this and more, we're delighted to be joined by 3 distinguished panelists. Sohail Agha is a senior program officer at the Bill and Melinda Gates Foundation. Harini Kannan is a research scientist at JPAL South Asia. And Mark Engelbert is an evaluation specialist at 3IE and one of the technical leads on our immunization evidence program, who also manages 3IE's development evidence portal. The impressive bios of all of our speakers are available on 3IE's Evidence Dialogue website, and I invite our participants to take a look. To our panelists, welcome. Thank you for being here. I'd like to kick off by asking Mark to give us an overview of the evidence gap map and some of the broad conclusions and implications for policy and practice. So Mark, over to you.
Great, thanks very much. I'll be presenting here. Okay, so I would like to start by saying a bit about the motivating questions behind this kind of evidence mapping exercise that 3IE does. And so the purpose of this kind of mapping is to identify, so for the interventions that are being tried out in this field and the outcomes that we care about, where do we have evidence about which interventions are effective at improving which outcomes? How is that evidence distributed, like geographically? And where are the key gaps in the evidence where we need to invest more in research to be able to inform policy and decision making? So do want to point out one caveat about what evidence gap maps, or EGMs as we call them, do not do, and that is weight or synthesize the evidence. So this is sort of the main difference between an EGM and a systematic review. A systematic review will synthesize the evidence and tell you what it says. An EGM just maps out the evidence and shows us where we have evidence and where we don't. When we look at some of the sort of visual layout of where the evidence is, you'll see that there are certain types of areas in terms of interventions and outcomes where we have a lot of evidence, and certain areas where there's very little evidence. But having more evidence doesn't mean that we have evidence that the intervention works. There might just be a lot of information suggesting that the intervention is not effective. So that's important to keep in mind when you're digesting the information in an evidence gap map. But the way that we approach EGMs is pretty similar to the way that one would approach a systematic review. We start with a broad and systematic search of academic databases and institutional websites to try to find relevant impact evaluations and systematic reviews. And I'm not going to go through the details here, but this is just a summary of how we started with about 45,000 search results and winnowed that down to the included studies. And so we found 226 impact evaluations and 58 systematic reviews, as well as some ongoing studies in each category: impact evaluations and systematic reviews. So having gone through this process, once we identify the eligible studies, we can categorize them according to the interventions that they evaluate and the outcomes that they measure. And so we organize these intervention and outcomes into categories and put that in a matrix framework that I'll describe in a bit. But to give a sense of what the framework looks like, here's a part of our intervention framework. We have the categories that are grouped into these hierarchical groups. And so there are sort of two levels here of broader and more specific categories. There is an additional layer below this. So the categories on the right, each of them has several more specific categories within it in our framework. Too much detail to show here, but these are the broad categories. And so for the interventions, they're broadly grouped by who is targeted by the intervention. So that might be caregivers, health systems, communities or community leaders, or more policy and institution type of interventions. And so you can see here, this is a group of interventions that are all targeted at the health system and trying to improve capacity to deliver vaccination services. And we have a similar arrangement of outcome categories. So again, here are sort of two levels of the framework, and there's another layer of more specific outcome categories sort of below the categories that are shown here. But these are the main categories. There's a category related to the behavioral, social, and practical barriers that primarily caregivers face in accessing vaccination services. There are outcomes related to health system capacity to deliver vaccination services, those related to coverage of vaccines, and we have outcome categories related to lots of specific doses, so that we're able to say for each specific dose in the routine immunization schedule, how much evidence do we have about interventions that are effective in making sure that children get that dose. And finally, health outcomes, so things like mortality and morbidity from vaccine preventable diseases. So once we've categorized all of the studies according to their intervention and outcome categories, we place them in a matrix that looks like this. And I'm not sure how well people are going to be able to read the text, but this is online, and you can go visit the site, and this is an interactive map. So I'll give you kind of a schematic description of how to navigate it and the general patterns we see here, but we encourage you to go check this out online and play around with it there. So we have the interventions that are listed here on the left side, and those form the rows of the matrix. And we have the outcomes along the top that form the columns. And so there's a cell for each intersection between an intervention and an outcome. And each cell contains a series of bubbles that represent the evidence that we found about the effects of that intervention on that outcome. So the gray bubbles are impact evaluation. And so the greater the size of the bubbles, the more impact evaluations we found. And the colored bubbles represent systematic reviews. And so we conduct critical appraisals of all of the systematic reviews that we include in the map and assign each one a confidence rating based on the methods used to conduct the systematic review. So the red, amber, and green bubbles are sets of low, medium, and high confidence systematic reviews. So having explained the layout a bit, I'd like to discuss some of the broad patterns that we're able to see just from this snapshot. So you'll see that the right side of the map is very densely populated, and this is the outcomes related to vaccination coverage. So it seems like there's just a lot of evidence on that set of outcomes. Over on the left-hand side, it's not empty, but it's much more sparsely populated, but there is decent concentration of bubbles representing evidence there, suggesting that we have sort of a moderate amount of evidence about how interventions affect these behavioral, social, and practical barriers to vaccination. And then we basically have a great big hole in the middle, suggesting that we have very little evidence on outcomes that are related to health system capacity to deliver vaccination services. And one thing I'd just like to highlight is this doesn't necessarily mean that we have very little information about outcomes related to health system capacity in general. It's just that when these things are studied, they don't seem to be studied directly in the context of vaccination services. So with that, let's take a closer look at how the evidence is distributed. So this shows the number of studies that we found for different intervention categories. The blue bars are impact evaluations, and again, the colored bars are the low, medium, and high confidence systematic reviews. So there's a lot of information here, but just to highlight a couple of patterns, we see a fair amount of evidence for interventions related to education and training, for incentives, for health system governance, and for community-oriented interventions that focus on community and dialogue. However, with respect to other aspects of engaging communities, like working with local leaders or tracking and registering vaccination delivery within the community, we see a lot less evidence. The policy and like education-oriented interventions, we see a lot less evidence there. Looking at the distribution of outcomes, we see that there's a pretty heavy imbalance, kind of like we saw in the matrix, that things are very heavily skewed towards coverage outcomes and a lot less evidence on the important intermediate outcomes that are related to the barriers faced by caregivers and especially health system capacity. In terms of how the evidence is distributed geographically. So in this figure, the more red the country, the lower their coverage rate of the third dose of the DPT vaccine. So this is WHO data, and delivery of the DPT-3 dose is often used as a sort of a proxy for the routine immunization overall. And so that's the country colors. The numbers within each country represent the number of impact evaluations that we found based in that country. And so the main pattern to observe here, I think, is that we're often lacking evidence in the places where we need it most. So places like Somalia, Papua New Guinea, South Sudan that have quite low DPT coverage rates also have very limited, or in a lot of cases, zero availability of impact evaluation evidence as far as we've been able to determine. So it's quite striking that those are the places we need this evidence the most, and it really seems to be lacking there. Just looking at the numbers, there's a pretty uneven distribution of evidence in general, where you have countries like India, where there's been a lot of studies, and then a lot of places in sub-Saharan Africa where there's fairly limited amounts of evidence. One notable exception to the general pattern that the countries with the lowest coverage rates also have very limited evidence is Nigeria, which has a fairly low coverage rate, but a moderate amount of evidence with 15 impact evaluations that we found based there. One of the most important things I think that we do when conducting an evidence gap map is look at how, or in a lot of cases, whether studies are attending to equity considerations by presenting disaggregated results for different vulnerable groups. So the overarching finding here is that it's vastly more common for studies not to include any analysis for this sort of this kind of subgroup analysis or presenting information that allows us to determine the effects of the intervention on some of these groups, like hard to reach population, or presenting, does the effect of the intervention differ based on vaccination for boys versus for girls? Just the bars saying no, the impact evaluations or the systematic reviews did not include any information on the effects for those groups. The no bars are a lot longer than the yes bars here, and that's the overarching pattern. And finally, we looked at whether studies are including any kind of information about the cost of the intervention. So the red bars here indicate that impact evaluations and systematic reviews that provide no cost information about the intervention. And again, we can see those are a lot longer. It's much more common for studies to report no information whatsoever about the cost of the information. And so a key component of cost effectiveness analysis, namely the cost information, is lacking. So people are presenting effectiveness results, but this kind of cost information and being able to conduct cost effectiveness analysis is really, really crucial for decision makers. It doesn't do you much good to know how effective an intervention is if you don't know how much it costs. And so this is a pretty major gap that we've identified as well. So just to sum up some of the conclusions from this, the evidence on outcomes is really heavily focused on coverage. And so we are just lacking a lot of information on how to affect these important intermediate outcomes, like caregiver barriers and the health system's capacity to deliver vaccination services. And again, there's just seems to be limited attention in the research literature or the impact evaluation literature specifically on attention to the health system strengthening, again, specifically in the context of vaccination. There is a need for a greater diversity of countries represented in the evidence base, especially those with the lowest vaccination rates. And again, equity considerations, the attention to that is lacking, and most of the research is just not designed to be able to identify impacts on vulnerable groups specifically. And again, we really need that cost evidence, and there's just not a lot of it in the evidence base right now. So that's it from me, at least for now, and I'll turn it back over to Sebastian. So thanks very much.
Wonderful. Thank you very much, Mark, for walking us through the EGM, really a wealth of information out there. For all of our participants, we've sent through several links in the chat, including to the 3I's Development Evidence Portal, where you'll find this EGM and many others, and links directly to the EGM and a summary. So go ahead, look in the chat function, and hopefully you'll be able to pick out those links and access this important resource. So Mark, picking up from where you left off, of course, in 2015, when we launched this program, no one had in their mind that a pandemic was looming several years later. So I'm wondering, what are your thoughts in terms of insights that we might be able to extract from the EGM that you think might be relevant for policymakers and researchers in the context of our current COVID pandemic?
Yeah, I think that's sort of the key question here is, well, we did this work assembling all of this information on routine immunization in low and middle income countries. And just say our search was done in sort of early 2020, or I think it was May 2020. We did our last version of the search. And so, before any evidence specifically on COVID vaccination would have been available. And so we've assembled all this evidence, and now we have a new problem. And we need to think about, okay, how can we, and to what extent can we generalize from this evidence that we've assembled to this new context, this new problem of COVID vaccination. So I have a couple of thoughts about that. So one is, in order to be able to generalize, you have to have evidence to generalize from. And as we covered in the discussion of the map, there are areas where we just don't seem to have a lot of evidence, again, that's specific to the vaccination context. So with respect to health system capacity to deliver vaccination services, again, we just don't see very much evidence on that. So it's good that we know that, because it saves from going and looking for that evidence, but it does suggest that if we're going to rely on evidence to tell us how to strengthen health systems in general, we may need to look to other contexts where health system capacity has been studied. So, how do you increase the resources available to health workers? How do you improve the way that information is shared throughout health systems? These are probably things that there is evidence on, maybe not specifically in the context of vaccination, but if that evidence can be sort of identified and brought to bear on this problem, that does give us some leverage. In terms of places where we do have evidence and want to think about how can we generalize, this is something that it's a topic that 3IE thinks about quite a bit, just transferring evidence from one context to another. So I'll just say a couple of things about that. So one is to just be very careful in the way that we define certain phenomena, or the way that we describe certain evidence. So just to give an example, we might think that there's a general phenomenon of vaccine hesitancy, and so if we have information about interventions targeting vaccine hesitancy in the context of routine immunization, that's going to tell us how to address vaccine hesitancy in general. But there was a recent survey in India about COVID vaccine hesitancy, and they found that there was quite high COVID vaccine hesitancy, even in areas like Punjab, where overall vaccine hesitancy seems to be low, given that these places have pretty high vaccination rates in general. So around 90% of children in Punjab were fully vaccinated. And so it seems like there's a discrepancy between the kind of vaccine hesitancy that comes into play with routine immunization versus COVID. And so we just need to think very carefully when trying to transfer evidence from one context to another. One thing that we, as demonstrated in the map, there's quite a bit of evidence in the context of routine immunization about the use of incentives for caregivers. And generally speaking, I think it's one of the things that's been identified as more effective. Again, we try not to go into results much in an evidence gap map, but that's my understanding of kind of what the evidence shows. And so that's something that we can perhaps leverage. And if we think that the general principles underlying human behavior there, where you provide incentives for people to do things, and they that helps them get over certain hurdles and motivates them to do that thing. That's something that hopefully is going to generalize, and so we can take some of that evidence on incentives in the context of routine immunization and bring that to bear on COVID vaccination.
Great, thank you, Mark. Let me stay on the same topic and now turn over to Sohail and Harini. So in your views, what kinds of patterns in the distribution of evidence across the intervention outcome categories or geographies do you see as having the greatest utility to researchers and policymakers in the context of COVID? So maybe let me start, Harini, with you, and then we'll turn it over to Sohail.
Thank you, Sebastian. I think, just going back to what Mark was saying, I think one thing which is very evident here is COVID vaccinations are very different from childhood vaccinations. So I think while a lot of the evidence, especially surrounding sensitization programs, are helpful, we must also remember that the sensitization programs in routine immunization is usually focused on the mother or the grandmother in some cases. But in this case, the focus really has to be adults, many of them men who haven't actually heard this kind of messaging before. And anecdotally, we are hearing that a lot of these vaccination decisions are made at the household level. So there's actually you have to factor in the differing hesitancy within household members and see how best to communicate with them. So I think that the point is to look for, as Mark was saying, evidence from a slightly different sector and see how that kind of messaging and sensitization has led to behavior change, especially among the youth or the men, and see if we can use those learnings and try and replicate them in this particular context. The other thing is, of course, incentives always work. They're great nudges, but we've also seen that vaccine hesitancy is very high with respect to COVID-19. So even in countries like the United States, there are incentives out there, but after a certain point, you hit the wall of vaccine hesitance. So in that case, what do you do? So you really have to understand what factors drive hesitancy. And I think we don't know that yet. So Mark was talking about a survey that happened in India. And in fact, JPAL is in the process of doing a similar survey. And I think there is a lot to learn, which will really help us to tailor interventions that can really target specific factors of the hesitancy. The other thing is, I think misinformation is a big deal with COVID-19 vaccination, a lot more than perhaps even the routine immunizations. And we might have to look at evidence from other sectors, let's say those which are combating fake news, and see how that might actually be useful in this context. Another study which was done recently by MIT affiliates it's very interesting, which they said that stop focusing on talking about vaccine hesitancy, but telling people that so many people in your country were actually getting the vaccine or were wanting to get the vaccine led to improvements in vaccine coverage. So I think these are the kinds of things that we want to be looking at. So it's probably now is the time for us to broaden our horizon and look for evidence from other sectors and see how that they can apply in this particular context. Thank you.
Thanks, Harini. Sohail, we'd love to get your thoughts on this.
So I think that, this literature review, the systematic, as Mark mentioned, it's not a systematic review, but this gap map has been really valuable in terms of telling us what information is available. I think what is, to me, the most interesting is where evidence is missing. And there are quite a lot of areas where evidence is missing. And I believe that that is generally a problem with how social and behavioral sciences have been used in development. So it goes, I think it goes beyond immunization. So, for example, some of the areas that are missing with in terms of evidence, one of them is convenience of vaccination, or the actual cost of vaccination, or physical effort required for vaccination, or the mental effort required for vaccination, or the social norms around vaccination. So there are these huge missing gaps in terms of evidence, and I believe that it's because we have not had a really useful practitioner-friendly model of behavior, which people have agreed upon and have used systematically across different health areas, including immunization. I think immunization has been particularly weak, but this is true for many other health areas as well. So what we don't have is a theoretical framework against which we try to generate knowledge. And we end up with looking at coverage, lots of evidence on coverage, which tells us very little about why things change. We don't have intermediate variables of behavior that are agreed upon. And so I think we have a general problem in the field of public health, which goes beyond immunization, that continues to plague us and will continue to plague us until we sort this problem out. And it's evident in what is missing in the gap map. So there are some practical, at the Gates Foundation, I've been working on demand and behavior change for the last 6 years. And I've been searching high and low for a behavior model which actually can be used by practitioners and explains a substantial amount of variance in behavior or coverage in this instance. And I have identified a model, and I've been working on it and trying to generate evidence. So there are a couple of models which are out there, and those models actually very much focus on the type of information that is missing in your evidence gap map, and which are the things that I mentioned. The whole aspect of convenience of so we continue to focus on motivation. Every time you hear someone talk about behavior, it's all about motivation, as if motivation is the only thing that mattered. But if you look at actual empirical evidence of the level of motivation versus the level of ability in a population, I've been looking at this for Nigeria now fairly carefully. Motivation levels are fairly high for vaccination. And by fairly high, I mean 2/3 of the population in Nigeria, based on a Kantar survey, is willing to get a COVID-19 vaccination, which for me is pretty high for a population like Nigeria, where misinformation is rife, where vaccination rates are generally quite low. But when you look at the other factor, the ability factor, it's much lower. So 38%, according to that survey, 38% of the population of Nigeria feels that it's easy to get vaccinated. This is the adult population of Nigeria. So we have these very big gaps right now, and just by continuing to motivate, or if we think that motivation is a solution or incentive is a solution, if we continue to do that, we will continue to remain in this kind of situation where we don't have a full understanding of what drives behavior, because we don't have agreement on what behavioral models are practical, useful, and get us to the kinds of answers that program planners need in order to implement programs. So that's, I'll stop here.
Great, thank you so much, Sohail, and we'll take note of the dearth in a really useful model that the practitioners can use. I think that's a really important insight. So I want to turn back to you, Harini, and maybe dive a little bit deeper on the question of sort of the missing middle in intermediate outcomes. So, as we've touched upon, we don't actually see a lot of evidence on intermediate outcomes like vaccine hesitancy, right? Which you've pointed out has come up a lot in the context of the COVID discussions in lower middle income countries. So I'm wondering if you could share your thoughts on how we address this evidence gap map, in the current context of urgency with COVID. And more generally, why the intermediate outcomes tend to be overlooked in evaluations. So as a researcher, how would you think about this? How could we think about addressing this issue?
I think if as a researcher, if we had a chance to run this COVID vaccination campaign, I would have recommended we do a vaccine hesitancy survey, really in-depth one across India or even across the world before the vaccines came out. So you will be prepared to address these hesitancy questions when the supply has stabilized and there is vaccines for people to take. Well, that ship has sailed, but in the case of India, I think there is a concern that we don't see vaccine hesitancy yet because it's marked by supply side issues. So if supply gets stabilized in the next 2 or 3 months, we might start wondering why vaccination rates are not going up, because that's when you will realize that there are vaccine hesitant people who are not yet vaccinated. So I would really think that this is the right time for governments to try and understand hesitancy. There is a concern that now that the COVID cases have fallen, they've stabilized a little bit, people might still feel that they don't need the vaccine. So that could be also another factor why you might see vaccinations fall off. And we need to be ready to deal with stuff like this. And I think, the way Indian vaccination is set up, we have the CoWIN where the registrations happen. We have very, very nice way of tracking outcomes. I think it's a question of the government partnering with researchers to be able to run really quick interventions to see what will improve take-up, because there's a very nice way for them to collect the outcome data. And it's a question of just willingness and I think ability for us to do this. So of course, this is, this is something which is will be wonderful if it happens. But to your point about, why don't we see intermediate outcomes? And I think, it also boils down a lot to incentives of researchers. I think the focus is always on the big picture, right? We go look at, what happened to the immunization rates. And we might not, while we might focus a little bit on hesitancy, we don't really make it a key component of the impact evaluations that we do. So for me, I think it's a focus on trying to go back and do a very strong theory of change that should be adopted, and try to gather data along the way to try and validate that, and not just focus on outcomes. And also really adopt mixed methods to understand sort of the behind the scenes of why you see something, right? And I think sometimes even worse when we have really well-functioning interventions, then the intermediate outcomes are almost completely forgotten because, hey, this thing works, and that's fantastic. And I think there's a role for donors to play here as well, right? If donors push for more researchers to collect this data, to report on this data, then the incentives are a little bit more better aligned. Thank you.
Great, thanks, Harini. We do hope to see more research coming out focusing on this area, and I think given the current context, I hope we will see that. Sohail, I'd like to come back to you, and as we've noted in the presentation, there is fairly limited evidence on how to reach vaccine hesitant groups or zero dose children. So do you think COVID has created avenues to test and evaluate strategies that are potentially effective to increase vaccination coverage among these groups, and maybe help fill some of these evidence gaps? And if so, how might that be?
So, I don't think it's necessarily COVID. Yes, there is an opportunity for more research, but I think until we get our models right, until we actually start using behavior models, I'm not sure COVID is going to be able to help us in this way. I think we need to be clear about what we are trying to measure, and what drives behavior, how do people change behavior, what are the intermediate outcomes, and until I think we get there, I'm not sure anything will help us. So I'll just kind of reinforce my first point. We need to be much more cognizant about practical models of behavior that can be employed across the board and are simple enough that are widely available to researchers. Social scientists have come up with, as you know, there are more than 80 theories of behavior change. And no two social scientists, as far that I know, would agree on which one to use if you were to ask them, hey, this is a situation, which theory, whether there's reasoned action or cognitive dissonance or whatever. There's no agreement on this. So in my mind, there has to be agreement. And the issue with impact evaluations is that while they're extraordinarily useful, they actually don't tell us again about why things change. And unless they are based on theory, as I think Harini is referring, they're not going to give us the answers. There has to be, in my opinion, a much more continuous learning approach. We in public health are not trained in that way. This is what happens in the commercial sector. You test and you pilot and you iterate and you improve and you learn a little bit and then you move forward. Not to say that you shouldn't do an impact evaluation, but that's only baseline, endline, or midline. But what about all the middle stuff? What's happening? What changes are taking place? What is measurable? Not necessarily in terms of coverage, but other intermediate factors. So unless we change our way of learning, I'm not sure if we will come up with anything better than what we have. Sorry to be a little pessimistic.
Great, Sohail. It's always good to get a reality check, and and also I think calling into importance, the value of complementary evaluation approaches, right? Process evaluations, qualitative methods that might be able to be fielded, in a slightly more timely manner and yield insights that sometimes at least sort of the traditional way of doing evaluation may not necessarily feed those sort of immediate informational needs. And I think the value of theory is well taken. So Harini, you were one of the principal investigators on an impact evaluation that was funded under the immunization program. And you evaluated 3 separate interventions to improve immunization coverage in the Indian state of Haryana. Given the significant positive findings of the study, we heard the government was keen on scaling up these interventions statewide. How's COVID-19 impacted the scale up of the intervention, both in scope and practice? And can COVID vaccination efforts be integrated within these routine immunization programs?
So as you might imagine, once the pandemic struck, the state missionaries sort of pivoted to focus on the situation itself. So I think it's only now we've sort of gone back to these discussions. I think that there is some movement on restarting some of the pilots in a couple of districts. So that's started again, and we hope that the third wave doesn't derail that. And I think there's also going beyond just RI. I think there's a focus on trying to see if one of the interventions, which was the gossip, so the social network interventions, there is an interest to see if that would actually work within the context of COVID-19 vaccinations as well. So those are all sort of chugging along, and we hope to see that happen. Again, very, very dependent on what happens with the third wave and so on. Yeah. So that's where we are.
Great, thank you, Harini. Sohail, let me just bring a question, one more question on you, and then I'm going to open up a question for all the panelists before we turn to some of the really great questions and comments that are coming through on the feed. What do you see as the highest priorities for investing in further evidence in this area in particular?
I think the highest priority is test and learn interventions right away. Just continuous learning, test and see what works, and then disseminate it as soon as possible, and keep the government involved so that they have the option of scaling up. To me, that by far practical learning is the highest priority. And I think people involved in impact evaluation have a lot of contribution to make to that.
Great, thank you, Sohail. So now we're going to come back to child immunization, which was the focus of this program of evaluation work. And I'm going to actually open it up to all of the panel members. And so, since early on in the pandemic, public health experts at organizations such as WHO and UNICEF have really been sounding the alarm about potential adverse impacts of COVID-19 on routine immunization coverage, which, in certain contexts, I think there's some evidence that it may be declining, particularly in some areas of lower and middle income countries. So, there's some growing concern that we may be fighting additional epidemics soon if vaccination coverage to prevent diseases such as measles or polio fall below optimum coverage levels. So besides disrupted supply chains and overstretched health systems, there appear to be a risk of prioritizing COVID vaccination programs over other health interventions. We already have large evidence base on what works to improve immunization on children in lower and middle income countries. How do you see that we could leverage that evidence to ensure that routine immunization doesn't stagnate or decline in the present context? So let me open it up to all three of you. And I don't know if any particular order, maybe invite Mark to come in first if you have any thoughts on that point.
Sure. So one of the key motivations behind doing an evidence gap map is to be cognizant of what we don't know. And so kind of have to come clean and say, on this question, I don't know. This is a very difficult question about how health systems at a massive scale can juggle two extremely important balls in the air with routine immunization and COVID vaccination, and that's a very difficult problem, and it goes well beyond the evidence that we've assembled in our map. But just a couple of observations just from having thought about these problems. So obviously, the more that we can identify ways to make routine vaccination and COVID vaccination efforts complementary rather than in competition for resources, that's going to help the case for sustained attention to routine vaccination. So there are maybe a couple of avenues along those lines. So we know that it's going to be the same groups are going to be most affected by barriers to routine vaccination and barriers to COVID vaccination. These are groups that are hard to reach. They're vulnerable for a variety of reasons, and are just going to face the biggest barriers. And so, as we are trying to deconstruct those barriers, think about ways to do that. Whether it's addressing different types of vaccine hesitancy in different ways, or just improving. As Sohail was talking about, the just the practical ease of obtaining vaccination services, that can be done simultaneously for routine vaccination and COVID vaccination. And one thing that I'll mention, there's a complementary project within the 3IE immunization evidence program that's a systematic review focusing specifically on community engagement strategies. And this is something where there is a decent amount of evidence, at least with respect to certain interventions. And that seems like an area where there's going to be a lot of complementarities and some synergy between working with communities to address barriers and allow communities to develop their own solutions for whatever the particular barriers to vaccination in their communities that are, again, there's going to be some discrepancy between COVID and routine vaccination, but it seems like, engaging directly with communities is going to be a really good place to start in both cases. So I think that's a promising avenue.
Great, thanks, Mark. Sohail, can we come to you next for your thought on this?
Sure. I'm not sure if I'll be able to add a lot more to what Mark has said, but to me, one of the interesting things are that it seems, at least in Nigeria, which is one of the countries I'm a little familiar with, that the geographic response to COVID is very different from the response to routine vaccination. So the highest rates of routine childhood vaccination are in southern Nigeria, where the level of vaccine hesitancy for COVID is also the highest. And the highest likelihood of uptake of vaccines appears to be in northern Nigeria, where rates of childhood vaccination are much lower than in southern Nigeria. So to me, there are some very interesting things happening with this, and to try and understand why that is, and whether this is a pattern across other countries as well, whether some of the regions doing very well in routine immunization perhaps are not doing as well, or perhaps are doing poorly in terms of likelihood of uptake. And is there some kind of room or window of opportunity there to build upon? So again, this is just conjecture on my part, but it's a great question. I don't have a good answer.
Thank you, Sohail. Harini, anything you'd like to add in?
I think I just want to say that, for me, it's also a question of optimization at the lowest level, right? So we have routine immunization conducted by frontline workers once a month, or once a week rather, in select villages. But COVID vaccination is something that you want to do every single day, and we need to really pick up the pace in case of India. I'm actually concerned that there'll be impact if you involve the frontline workers in COVID vaccination on all the other services they provide, like your nutrition days, your ANCs. So it's a much larger problem than just a fall in routine immunization. So it's very tempting to use this infrastructure because it is a wonderful infrastructure, but somebody has to really think through this and map this out well to make sure that both of these things are sort of balanced.
Thanks, Harini. Okay, so I'm cognizant of the time. We have lots of really, really great questions coming in from our participants through the chat. So hopefully we'll be able to get to at least a couple of them. Our first question comes from Ashok Kar, and it's addressed to all panelists. Ashok asks, technology and M-health, which I'm assuming is mobile health, seems to have low evidence compared to other parameters. In this digital era, when information collection is smart and easier, why do we see low evidence in this area? Any thoughts on this of why these areas, particularly of technology and M-health, might seem to have lower amounts of evidence?
Yeah, so it would be helpful to clarify. This is partly, I think, a bit of an artifact of the way that we sort of chunked things in the map. So we did find a number of studies on things like SMS reminders to caregivers and even health workers in some cases about when vaccinations were due and things like that. We thought that the key underlying sort of theories of those were more about just providing information and motivating caregivers. So we grouped those with like incentives and motivation for caregivers. And so that's where they show up. The technology in M-Health was really about platforms that health systems would use for tracking and sharing information. And so that's where we've seen a lot less evidence. And I don't have a great answer for why we haven't seen a lot of study on that. I would invite the fellow panelists to comment. It may be just because those technologies are a bit newer and have just had less opportunity to be studied. But yeah, I'm not really sure about that.
Any thoughts, Sohail or Harini?
No, I'm afraid not.
No, but I also feel that sometimes it could also be the artifact of if you're trying to partner with someone to do this, there's sort of economies of scale. So they may not want to say, if it's a randomized evaluation, randomize the rollout of M-Health. So you might have like layering intervention where M-Health is sort of across the board. And on top of that, you have something else, which is what we had in the Haryana immunization study. So that could also be the reason why we're not seeing enough evidence yet. But that said, I think this is a very ripe for a lot more interventions. We do need evidence.
Okay, I'm going to move on to a couple of questions, I think mostly addressed to you, Mark, really more about clarifications on the EGM. So David Curry is asking, what's the language range of the literature that was assessed and mapped within the EGM? And we have another participant who is asking whether situation analysis or rapid assessments are included as part of the search.
So I did type an answer to the language question, but briefly, we didn't impose any language restrictions. So in any study that we found that we would include, regardless of what language, but our search was conducted in English, so that limits just how much we would retrieve in other languages. But we did have some studies in French, Spanish, and Portuguese included in the map. And as far as situation analysis, no, that was outside the scope of the map. So there may be just a general thing about evidence gap maps. I mean, there's going to be lots and lots of useful insights from research and studies that fall outside the scope of the map. So that may, in fact, be a really good place to go to get evidence that was outside the scope of this particular map.
Okay, great. Thanks, Mark. And let me end off with one final question from Ramadan to Sohail. Ramadan says that there's limited knowledge of restrictive medical norms. Is it true that only the social norms are responsible for vaccine hesitancy? So I guess we're getting at here the difference between medical norms and social norms. Any thoughts on this point?
I would guess that both are important. There are lots of different terms being used for norms. So I tend to think of social norms as those in the general population and medical norms perhaps as those within the medical community. My guess is that medical norms are also very important. And part of it is that healthcare providers are reluctant to get vaccinated in some countries. And we know there's a lot of literature showing that if healthcare providers are not confident themselves or they're not vaccinated themselves, they're not going to recommend vaccinations to others. So there is a difference between the two types of norms. I think both are important. And at the base of it is, I think, really the need to make sure that healthcare providers are fully on board, which is, I don't think, the case in many countries right now. I was just looking at some systematic reviews, and it shows that between 23% and 77% of healthcare providers across many different countries are willing to take up a COVID-19 vaccine. And one of the systematic reviews is on the United States as well.
Thanks, Sohail. And I see lots more really interesting questions, comments coming through the chat. Unfortunately, we're not going to have more time to get through all of them, but I would encourage us to continue this conversation online on Twitter, for example. So thanks to all of the participants for sharing your valuable thoughts and comments with us. We will take note of all of them. So we've learned a lot about the distribution of and gaps in the evidence on routine vaccination in lower and middle income countries through this program of work, especially the dearth of research on on intermediate outcomes, on vulnerable groups, on cost effectiveness. It was great to have the launch of the EGM. This is a fantastic resource. Again, the links to that resource are available in the chat. We hope that all of you take a look and make use of that tool. I'd like to thank again all of the panelists and the whole 3IE team that made this event possible, and to all of you for joining us in this engaging panel discussion. The live stream of this video has been uploaded to 3IE's YouTube channel in case you'd like to share or rewatch the webinar. If you'd like to continue the discussion on Twitter, tag at 3IE News with your tweets. Again, a great place to continue the conversation with all the great questions that are coming through. And you can also subscribe to email updates from 3IE by visiting our website, 3ieimpact.org, to learn more about future events in the Evidence Dialogue series. Thanks again to all of you. We will see you soon.
Thank you. Thank you.
Thank you.
Thanks very much. Bye.
Bye-bye.